Hey everyone, Dr. Luke Pedersen here, physical therapist with the Knee Replacement Therapist. In this episode of the Need to Know Show, we have a special video. We have a guest here, my brother, physical therapist Jordan Pedersen, the other half of the Knee Replacement Therapist. So I'll give him a minute to give a brief introduction.
Hey, so my name's Jordan Pedersen. I've been a physical therapist for about 10 years now. I work mainly in outpatient orthopedics in a hospital setting. I also do some home health, and I also do telehealth. A couple specializations I have. I'm a fellow of the American Academy of Orthopedic Manual Physical Therapists, and I'm also a certified McKenzie therapist. So that's just a little bit about what I've done so far in my 10 years as a physical therapist.
Great. So today's video topic, we're going to talk about increasing your knee flexion or your bending after knee replacement surgery. So Jordan, when you have a patient who is post-op knee replacement surgery, what are your goals for bending knee flexion range of motion?
So typically after a knee replacement surgery, a goal that you hear a lot is 120 degrees, which I think is a fair goal to expect after surgery. The reason why this goal is usually set at 120 degrees is that it's going to cover a lot of your basics, such as the ability to walk with a normal gait pattern and going up and down stairs. So 120, I would say, is a good goal. If you're looking to do a couple activities that are higher level, say you're going to try to get in and out of a bathtub, or you like to garden a lot, you might want to stretch it a little bit and aim for, a little higher than 120 degrees.
All right, very good. So say you have someone who is maybe a day out from surgery, kind of what's the timeline look like? What are some of the benchmarks that you're looking for someone as they progress through their rehab?
So I like to break it up as far as how we're going to progress flexion or bending range of motion into the phases of healing. So I would say, I'll break it down real quick. So you could say the first 7 days we could call the acute phase. And this is just a ballpark. 7 days to 7 weeks, we call that the subacute phase. And then after 7 weeks, chronic phase. So what we're looking for in the acute phase is we're not focused so much on gaining tons of range of motion, but we're focused on getting control of your inflammation, reducing your swelling, and getting your pain levels low. So as far as what to do in the beginning phases is we want to work from no range to mid-range. So you're starting in the beginning ranges. So think about numbers from, some people might start from a low number, 40 degrees of flexion, and we're shooting to get to that 90-degree mark. 90 degrees is a nice mark. Everyone can see that angle, and that's what you're working for in the beginning. So get rid of swelling, reduce pain, slowly working your way up to 90 degrees. So that'd probably be the beginning phases.
Yep. And of course, we have to give the disclaimer that, everyone's going to be a little different, and these are kind of general benchmarks or guidelines, but there's definitely going to be some variation within these ranges that we are keeping an eye on and targeting. So if you had someone kind of big picture wise, what might be some of your important advice or important education that you would give someone who is post-op surgery and is working to try to improve their range of motion? What are some of the important keys that they should keep in mind throughout the process?
So I'll probably fall back again on, it depends on what stage you're in. So, and the physical therapist will help you with that. So in the beginning, when there's chemical dominance or an inflammatory dominance, meaning mainly there's a lot of swelling in that area, the physical therapist will work with you with doing gentle stretching. So you're not going to be pushing as hard in the beginning. So working from, like I said earlier, the beginning range to mid ranges. Then after the first 7 days, approximately, as the swelling starts to go down, the physical therapist will kind of teach you that now we're moving into more of not just the swelling phase, but as we call it, almost like a chemical mechanical interface, meaning now that we're moving out of the swelling phase, there's some tissues now that are going to be able to accept load, accept stress of a stretch. So when you're ready for that, the therapist will tell you, okay, let's start pushing it a little further and increasing the frequency or the intensity of your stretches. And then lastly, the chronic phase, mainly the swelling's gone, pain's under control. That's a time, you're you're 7 weeks out, 8 weeks out, 9 weeks out, where we can do more aggressive techniques, meaning we can hold certain stretches longer. We can use contract relax techniques where you actually push into the therapist's hand and then they can stretch you after. So I would say important thing is make sure you have a good communication with your therapist on, asking them what's the correct intensity of my stretches and what's the correct frequency to do my stretches, and they'll know because they'll be able to guide you as far as which phase you're in.
Yeah, that's great. So of course you hear the phrase, I'm sure that, sometimes people say no pain, no gain. And then you have people on the other end of the spectrum that, you shouldn't have any pain at all. Kind of what are your thoughts in terms of, should it be painful when you do these? Should you go push it into pain? Kind of how would you guide people in that regard?
Yeah, so you definitely want to have the right expectations before you even go into the surgery. So I tell a lot of people, take a look at learning about why we do have pain in general. So a new topic, a new education that we're giving therapists or patients is called pain science. And it's basically just the basics of, why we have pain. We have nerves in our body that send signals to our brain. And then our brain interprets how we feel with those signals. Either the pain's very high, the pain's very low. I know that's kind of a long answer, but the short answer to that is you're going to have pain throughout this process, and that's a normal thing. So you were saying no pain, no gain. Is that what you were talking about?
Mm-hmm.
So as far as no pain, no gain, I typically, as a therapist, I want to clarify that with the patient. I like that they're motivated to push themselves, and that's usually a good patient that says that. But it depends, once again, back to those phases. So if we're in the beginning phase, swelling is the dominant issue in the picture in the first 7 days, we're not going to be pushing hard, because if you push too hard, you're going to just further exacerbate the symptoms and increase the swelling. Now, let's say we have someone that's struggling with their range of motion 6 weeks, 7 weeks, 8 weeks out, and they don't have a lot of swelling, their pain's under control, then yes, some of those stretches do have to be pushed into discomfort or pain, but it's controlled. So I give people specific parameters. I tell people, we're going to push into pain, discomfort, and we're going to do this because that needs to stress the tissue to actually help it remodel and lengthen. But I want that pain and discomfort to go back to your baseline within a 15-minute time frame. Anything longer than that, then we're looking at tissue damage, flaring it up for 2 or 3 days, and that's just going to set you back. So,
right, that makes sense. What would you say to maybe someone who is maybe a couple months out from surgery, or maybe even a little bit longer, and they seem to be stuck with their range of motion? They can't seem to improve it anymore. They maybe have plateaued a little bit. Do you think that, can you still make improvements at that point? Would you make any other recommendations?
So if I have a patient that's plateaued, the first thing is I don't change any exercises to begin with, but what I do is I look at the parameters and the dosage of exercises. So I want to make sure, are they doing the exercises at the frequency that I tell them? So if I see a patient on Friday and I tell them to do an exercise every 2 or 3 hours throughout the day, and they come in on Tuesday or something, they said, I did it twice this weekend, there's actually, you can't say that you've plateaued yet. It might just be that you need to increase the dosage of your exercise. Another thing is, if you're plateaued, not just looking at the frequency, but the intensity of your stretch. So like I talked about a second ago, stressing the tissue at the correct intensity is the only thing that's going to allow it to adapt and remodel. So if you're below the intensity, there will be no increase in the extensibility of tissue. If you overstretch, you're just going to get back in that swelling phase where you actually cause too much trauma to the tissue. So those are the first things I look at when someone's plateauing, 1 month, 2 months out.
Right. And I know we're not going to go over any exercises in this video, but of course you can check out our channel. We have all sorts of exercises. Do you have any particular exercises that you find the most beneficial or that patients tolerate the best, or do you kind of use a variety of different exercises and positions for working on range of motion?
Yeah, so I use a variety of exercises or techniques with patients. Let's say that we have all the parameters correct and they're still plateauing. That's when you can trial and error different techniques. So a common technique that we talk about as therapists is muscle energy techniques. I talked about it a second ago, but just trying to trick the body to relax before a stretch. So you're taking a joint or a muscle tissue to its boundary, and then the patient's actually going to push back against the therapist, and then the therapist is going to tell them to relax. And when they relax, sometimes what that does is allow for the patient to gain more range of motion. Other things would be other techniques we might try is soft tissue, either with hands or with a massage tool prior to stretching, which has also been shown to help reduce tone or fear before someone tries to bend their knee further. So when people are plateauing and they're doing the correct parameters, yes, I try a variety of techniques. So muscle energy, soft tissue, either manually or with a tool sometimes. So.
And would you do these, are these in a seated position or laying down on your back, or a little bit of both maybe?
Typically in the beginning, we're going to do exercises unweighted. So on a mat, which would be on your back, progressing to sitting, and then finally to standing. And then once again, that goes back to the phases of healing. We're going to protect the joint a little more in the beginning to get rid of that swelling. But then as you progress out of that swelling phase, your body's going to be able to tolerate stretches in sitting and half weight bearing and then full weight bearing. Another reason why you want to progress to the weight bearing positions is it's more functional. It's how we live. We're doing activities up and down the stairs, bending over and picking up stuff. So if I can get my patient to do a knee bending exercise, putting their foot up on a chair, a month out, that's going to be more functional as they're putting some of their body weight through the knee, as opposed to just bending their heel.
Yeah. And I know you talked about the intensity quite a bit, and you might have touched on the frequency too, but for, how often should people be doing the range of motion exercises? I know it might change as different phases of the recovery.
Yep. So when we're tweaking each patient, it depends on how their body is responding to the dosage that I give them. So if we're looking at specific findings, like if I'm looking at a baseline, say they're 90 degrees, and I send them some exercises, and the next day they come back and their swelling's more and their range is the same or even a little worse, then maybe I gave them too much frequency or too high of an intensity, and I'd have to back it off. If you wanted just like an example, I'm a McKenzie trained therapist, so typically I'm going to give you a high frequency. When you're in, let's say, 1 month out or maybe a month and a half out, I'm going to have you do exercises every few hours, but just 10 repetitions, just to kind of get that coordination down, keep the swelling moving out of that joint, and just giving gentle load and stress to those tissues so that they can start adapting and moving in the plane of motion that the knee moves in. So
yeah. And besides, of course, making those parameters of frequency, intensity, and trying to find the kind of the happy medium and the sweet spot, is there any other things that you see that maybe you would recommend not doing, or mistakes that people make when it comes to their rehab and recovery, maybe in general or in terms of range of motion? Or, is it normal daily activities are more or less okay, and, don't overthink it too much kind of thing?
I guess I would say the common mistakes I see is sometimes going into the surgery with the wrong expectations, not realizing that, the nerves don't understand. The nerves and the wires that, go to our spinal cord and brain and help us interpret pain, they don't know if that you have a brand new prosthetic in there. So you're still going to get pain signals. So some people are like, oh, I never knew it was going to hurt so much. you should have the expectation that there's going to be some symptoms. But I think a better approach would be for those patients that don't have the correct expectations is when you get that pain after surgery, you should be prepared and have a checklist of, okay, I knew this was coming. Now, what am I going to do? I need pain medicine. I need to do some meditation. I need to make sure I'm eating correctly. I'm try to get as much sleep as possible. Things like that.
Yeah. Yeah, and I think there's the research out there that they say that a real big reason that people have outcomes that they're not satisfied with is not having realistic expectations. And I think that talks about both the overall outcome in terms of the pain and what you're able to do after surgery. You're going to feel a lot better for most people, but you might not necessarily feel like you're a young teenager or 20-year-old necessarily either. And then also in terms of the rehab, it's not just a few weeks. It can really be, a couple months to really feel like you're back to fully recovered. Great. So do you have any other final thoughts or final recommendations that you would give people in terms of bending, range of motion, flexion, or anything in general?
No, I'd say do your homework. Make sure that you know what you're getting into as far as, once again, there's going to be different stages of healing, and expect to progress slow and steady. Also expect that there's going to be a little soreness and pain, and that's completely normal. And don't be afraid to ask questions before this process. And also, keep a good communication open with your doctor and your therapist as you do your rehab. So that would be the advice I'd give after a replacement.
Well, thank you very much for talking with us. If you guys are watching at home and you found this useful and found this insightful, let us know in the comments. We can easily do some more of these on different topics or just general Q&A type things. Be sure to leave a like if you got something useful as well. And of course, please subscribe to catch all of our videos. We post videos regularly on everything related to knee replacement surgery, recovery, exercises, frequently asked questions, everything else in between. So thank you very much for watching, everyone. Jordan, thanks for being on with us, and we hope to talk to you again sometime soon.